Hey guys, Cribbin Govender from the Gut Health Gurus podcast. I've got a background in food science, and today we have an amazing guest. It's such an interesting topic. I mean, it's something that's really dear to my heart and something that I've tried to talk about quite a lot over the years. And firstly, Chadi Nabhan, welcome to the podcast.
Thank you. Thank you so much, Kribin. I really appreciate the opportunity. It's a pleasure to be with you. It's the first time I am on an Australian podcast.
Wow, I feel very honored that you've chosen the gut health gurus to bring your message out to the world. And Chadi, what I like to do at the start of my podcast is to ask a very open question: who is Chadi Nabhan?
I'm a cancer doctor. I'm an oncologist, medical oncologist, and a hematologist. So I took care of cancer patients for 20 years in the clinic. I focused mainly on a form of cancer called lymphoma, which is a form of cancer that involves the lymph glands, the immune system, and sometimes the bone marrow. And I also did some research in the area, did some clinical trials in lymphoma and some investigations and all of that academic stuff. I then went back to business school. I decided to understand business and economics, and I got a degree, MBA in healthcare management. I became very interested in just the healthcare system as an ecosystem, and how can I help patients, not necessarily from the bedside, but more from a bigger picture. And so I transitioned from academic medicine, and I worked at a couple of companies. And the last one I'm in right now is a molecular profiling company that is really profiles tumors to understand the underpinning of the DNA and the RNA of cancers, so we can help in deciding what's the best treatment for patients. Along the way, I became a podcaster. I have my podcast. It's called Healthcare Unfiltered. It's not quite as famous and as popular as yours, but it's hopefully will get there maybe in the next 100 years. But I tackle various healthcare topics in general, whether it's policy, leadership, treatment, and all of that nature. And as you know, recently I became a book author. I wrote a book, which I'm sure we'll talk about, and it's just happened with serendipity. So at the heart of everything who I am, I'm someone who cares about patients with cancer, treated them, and I try to do my best to help patients.
Wow, what an amazing introduction. Thank you so much, Chadi. I'd like to dig a little bit deeper into your clinical days. So if you could jump into a little time machine and go back into firstly your research studies, the papers that maybe something might pop up and jump out at you that you'd want to share, and then secondly some potential case studies if you're open to sharing. Obviously, be as confidential as possible in terms of client information, but I'm really interested to hear about what your experiences around this area of oncology, which you specialize in.
Yeah, look, career-wise, we all evolve. Sometimes my least favorite question when somebody asks you, well, what are you going to do in 5 years? I'm like, who the heck knows? You have to have a cliche answer because, unfortunately, it's a cliche question. But I've evolved career-wise. In the beginning, I was very interested in novel therapies, what type of new treatments for lymphomas I could be involved in, whether it's clinical trials and the type of therapies I could give to patients. But I have to tell you, I became, after that, interested in two aspects that maybe your listeners and viewers will relate to. One is what we call real-world evidence. What does that mean? It means that sometimes patients are treated in clinic and in the real world differently than the patients that were on clinical trials. Because in clinical trials, things are so coordinated and they are so organized that you have to give the particular therapy at the particular time, at the particular dose, all of these things. You have to do the CAT scans and the imaging studies at particular intervals. The interpretation is also coordinated and centralized, but then a drug gets approved and it becomes available for physicians to treat. And then everything becomes a little bit different. You don't always treat at the same dose. You may do the scans in various intervals. So I became interested in understanding patterns of care in the real world, how they vary from clinical trials, and how can we really make sense of what happens in the real world. I also became interested in geriatric oncology. And geriatric is a tough topic because, you know, sometimes if you say somebody is geriatric, it means they're old. But the reality is more cancer patients are diagnosed over a certain age. The majority of cancer deaths are over a certain age. So statistically speaking, although we see cancers in all ages, but statistically, most cancers are in patients over the age of 65, and most people who die from cancer are over the age of 65. So we have to pay attention to that field because it is really important to understand how older patients get treated and what happens. As far as stories, Kriben, when you deal with cancer for so many years, there are so many stories to share, but maybe I'll share with you actually a story that got me interested in oncology. It's an old story because I'm not young anymore, but it really illustrates the heart of oncology and cancer patients. I was doing my residency. I was a first-year resident, and you know, you're nervous. You just don't know much about the field, and you're just basically getting into the patient's room, getting the vitals, and making sure everything is okay before your attending physician comes in, and you want to make sure you tell him or her the story. So I walk into this patient's room. She was in her mid-40s. She was young, beautiful, and just looked like an angel, honestly. It's hard to describe. I still, to this day, by the way, 28 years later, I still remember her face and her features. I walk in, and she had ovarian cancer, and her two daughters were sitting with her in the room. And I was just basically copying her vitals on a piece of paper. There wasn't electronic medical records at the time, and just asking her how she was doing. And she surprised me by asking a question, and she said, do you think I'm going to live until Christmas? And I was not prepared. It was October. I was not prepared to answer. I did not know what to say. I did not really feel I am qualified to offer a prognosis in something so sensitive. Plus, she wasn't really my patient. I was just covering the floor. And as if she sensed how uncomfortable I was, as if she sensed that she was not fair to me in asking the question. Imagine, she is the one who has the cancer. She is the one who's dying from cancer, and she felt bad for me. And she looks at me and she says, you know, don't worry. I just look forward to seeing you tomorrow with your smile. And right there and then, I realized the importance of human connection. It is so important. Patients with cancer strive for that. They are more than just a patient. You know, the human nature of the relationship is way more critical than the science. Science is important for the progress, but that human connection is there. And I fell in love with the relationships that you form with your patients with cancer. You know, I'll finish with this. When your health is jeopardized, whatever health issue you have, you are at the most vulnerable time in your life. Whatever health issue, because health is the most precious thing that you actually have. And imagine you're at the most vulnerable time of your life and you have to trust a complete stranger that you just met for the first time with your health, with your treatment decisions and everything. It's a privilege to take care of patients. It's a privilege to take care of people. But that story has stayed with me for over 2 decades.
Wow. That's really touching, Chadi. Thank you so much for sharing. What is cancer, Chadi? What is it, and why does it affect us, according to what you mentioned earlier, perhaps statistically more in the later parts of our life?
Yeah, look, so cancer, our body, I'll step back, our body is composed of various organs. Every organ is composed of cells. These cells, usually, they are present in a very harmonized manner. So they grow and multiply, and then they die, and they are replaced by new cells. So there's this balance between cell survival and cell death, and cells die. They have this natural life cycle. Something happens that basically tips that balance off. So either the cells continue to grow and they don't die naturally, or again, the balance of growth and death is completely off. That leads to the formation of growths or tumors. And these tumors could be cancerous and malignant. What that means, cancer is an imbalance between cell survival and cell death. And it could happen in any organ. There is no organ that could not become cancerous because every organ has cells. Now, why is the balance tipped off? That's the question, right? The balance tipped off for a variety of reasons, but generally there are mutations that occur in our body, in basically the structure of the cell, in the DNA in the backbone of the cell. So think of a building, right? And the building has bricks and walls. But these walls and these bricks could get damaged. Now, why would they get damaged? There are external factors that could damage these bricks. There are external factors that could damage the cells that we have in our body. Sun exposure could actually cause problems in the skin and all of these things, right? Smoking, it's external thing that we do. Pesticides that we'll talk about, and herbicides and things of that nature. So again, there are external factors that affect these cells, affects and damage these cells, so the balance is tipped off. There are internal factors, such as mutations that are actually inherited from fathers and mothers to the sons and daughters. I mean, there are certain familial reasons that usually occur, and you have really no say in it. It just happened to be passed on to you from birth. And then there are certain things pertaining to things just wear and tear, which is, to your point, pertaining to the older folks. I mean, buildings, sometimes there's nothing external or internal. It's just they're 100 years old, and you can tell they're older, so the bricks are not the same. The repair mechanism is damaged. Our body is actually an amazing machinery. So even though the cells are damaged, we're able to actually correct that damage that happens to the cell. As we get older, our ability to repair that damage becomes much more less. But is that just because of age, or is that because of other factors that also affect older folks as opposed to younger folks? I don't personally believe age by itself causes cancer. I'm not a firm believer that you tell somebody you have cancer because you're old. That's not a cause. But just because it happens more in older people doesn't mean that the age caused it directly. We have to, look behind the curtain and see, okay, what happened in that older individual. So, and in fact, I'm actually writing my second book now about cancer, trying to help cancer patients, all of this. But anyway, hopefully this simplifies things. I like to simplify it. Hopefully it's not complicated.
Sure, that's really simple. I appreciate you sharing that. So, in a nutshell, it's just a combination of genetics, which you mentioned, and epigenetics, so external factors that might push the body into a dysregulated state, which then causes the disease. So thank you so much for sharing. And I'm sure the audience might be really interested to hear it from a specialist like yourself. What are the typical treatment options available? And then secondly, what are the preventative measures that people can take to potentially prevent the disease in the first place?
Yeah. So if it's okay, Kevin, I want to step back just a little bit because
Sure.
I think that it is important to recognize that cancer is not one disease. Because when we ask a question such as how do you treat cancer and how do you prevent cancer, it implies that cancer is one entity, which is not the case.
Sure.
We all can agree that breast cancer is different than prostate cancer. It's different than ovarian cancer. It's different than brain cancer. And you get the gist.
Mm-hmm.
So I think there are certain risk factors that are more applicable to certain cancers, may not be applicable to other cancers. I mean, smoking as an example, I am not aware of smoking increasing the risk of brain tumors. But we all know that smoking increases the risk of lung cancer and bladder cancer. I'm not aware that smoking increases the risk of prostate cancer. Now, it doesn't mean it's okay to smoke, but I think it's important to recognize that the cancer as an entity depends on the organ. So the treatment and the risk factors and the causative factors differ. I think, to your point, though, there are certain general factors that are common sense that we should all try to adhere to that will help reduce our risk in general. I mentioned smoking. Alcohol is an interesting substance because the jury is out on it in general. There are some data on increasing the risk in breast cancer, for example, in pancreas cancer, but it's really not clear what that means. I mean, if you drink a glass of wine a week, is that really bad? Is it hard liquor? Is it beer? It's not clear. So I think it's controversial. So I always say from an alcohol standpoint, be a minimalist as much as possible. I think that would be my recommendation. Being exercise and staying fit is very important. Avoiding obesity is critical. There are 14 cancers that have been linked to obesity. Now, doesn't mean that the other ones who are not linked, it's okay just to eat wherever you want. I still think you need to indulge and enjoy food. Life is short and you have to be also reasonable, but you could do that in a healthy manner. You have to exercise and stay fit. And exercise does not mean you need to be running a marathon or doing a triathlon. Could be walking briskly, could be doing a lot of things. These are important. These are like in general things that I always recommend. I mean, professionally, I think there are certain professions that have increased risk of certain cancers, and I think these vary. As far as the treatment, of course, every cancer is treated differently. But when you think about the general types of treatment we apply to any cancer, sometimes surgery, and there are different ways of doing surgery, sometimes radiation therapy, sometimes chemotherapy, sometimes immunotherapy, sometimes hormonal therapy, sometimes targeted therapy. But which ones you select and what you do depends on the cancer itself. Lymphoma, as an example, is not treated surgically. Colon cancer is treated surgically. Breast cancer is treated surgically. So again, it depends on the disease.
That's a great clarification. I mean, you're completely apt in saying there's so many different types. It is a Gut Health Gurus podcast, so I'd be remiss to not dive a little bit deeper into the gastrointestinal path. So you mentioned colorectal cancer, colon cancer, stomach cancers. Is there any further light you can shine on these type of cancers and what we can be doing to potentially mitigate the risk?
Yeah. So maybe we'll talk about colon cancer a little bit. I think from a colon cancer perspective, the best way to divide it maybe into two categories. One category is the colon cancer that is passed on, genes that are passed on from family to their children that lead to increase the risk of colon cancer. And usually this is under the what we call the Lynch syndrome. The Lynch syndrome is a syndrome where patients have mutations in genes called the mismatch repair genes. And when this occur, they increase the risk of developing colon cancer. And when these, usually these patients should undergo colonoscopies early on in their life. For the ones that are not related to a genetic mutation that is inherited, most of these cancers evolve from polyps inside the colon. So because these polyps usually start forming at the age of 45 and above, the guidelines, at least today, in the United States, I'm not really sure in Australia, but in the United States, is to undergo colonoscopies at the age of 45. And depending on the results, you can repeat every 5 years or every 10 years and all of that. So that is in terms of what type of screening. As far as what might cause colon cancer, I think, GI oncology is not personally my specialty, but I think that there has been some studies on, red meat, for example, low fiber diet, and things of that nature. And you can criticize every study because there's no study that's perfect. So I try to tell my patients is eat healthy and be realistic. On the upper GI tract, in the stomach and the esophagus, we see these more prevalent in Asian countries, in Japan, China, and other areas. And it's been hypothesized that some of the reasons we see that is because of the type of diet that they have, which is very spicy, lots of smoking and alcohol together, because they become synergistic in terms of causing that type of disease in the esophagus and the stomach. So it's really important to pay attention to that. There are certain ulcers that occur in the duodenum and the stomach. They are caused by a bacteria called H. pylori. H. pylori is a bacteria that increases the risk of certain ulcers in the stomach and the first part of the small intestine. And there's some data that H. pylori could be associated with increased risk of gastric cancer as well. It is present and prevalent in certain countries, and sometimes it's there, it doesn't cause any problem. But if it causes ulcers and things of that nature, then it could actually have issues. So, not being a specialist in GI oncology, that's what I could say. I think, Kriben, you're probably familiar with a lot of research on the microbiome, right? There's a lot of data on this, and a lot of people are interested in the microbiome and how this really might affect gut health and everything else. And I think it's important to keep a close eye on that field. I'm very interested in that. I'm actually going to do a podcast on it as well. There's also maybe going back to the colon, patients with Crohn's disease, ulcerative colitis tend to have higher risk of developing colon cancer. So we usually watch them carefully and do lots of monitoring. So, it's important to discuss this with the doctor that is supervising the care of the patient.
That's amazing, Chadi. I appreciate you stepping a little bit outside the comfort zone to tackle a gut-related question, but I think all those points that you touched on are so on point. So thank you for sharing. I think a nice little segue there. You mentioned the importance of diet on potentially mitigating some of these risks, and the reason why I came across your work is the amazing book you've written, Toxic Exposure, and really going down the path of tackling some of these issues around pesticides. So I think that's a perfect way we can subtly segue into this famous trial that you've recently been involved in. So, firstly, in a nutshell, can you just let the audience know what the lowdown is with this very high profile trial you've been involved in?
Yeah, I did not. I never considered myself an expert witness, which means you are a physician that testifies in trials right and left. But as serendipity has it, I end up testifying in three major trials. In the first three major trials that were brought against Monsanto for their Roundup herbicide. So Monsanto is a company that manufactures Roundup. Roundup is an herbicide, and the main ingredient of Roundup is a chemical called glyphosate. And Roundup has been used in the United States commercially since 1974 by Monsanto. And in 1995, or in the mid-90s, Monsanto introduced something called Roundup Ready seeds. These are GMOs, and basically what that means is the farmers could spray Roundup on the weeds and they kill the weeds, but they also spray on their crops. And the seeds are not damaged and they're not affected and they're able to harvest and everything is fine. So the use of Roundup increased significantly. But what does that mean? It means that Roundup is present in our food because you're actually spraying on corn, soybean, alfalfa, cotton, everywhere. And this eventually becomes your food in cereal, in bread, and in everything. But this wide use of Roundup and glyphosate led the WHO, the World Health Organization, and a subdivision of that called IARC, the International Agency for Research on Cancer, to investigate whether glyphosate has any carcinogenic potentials. So they gathered some scientists and they looked at the published evidence. They looked at animal studies, mechanistic studies, human studies, and they issued a report in March 2015 that glyphosate, which is the main ingredient of Roundup, is a probable human carcinogen, which means it increases the risk in some patients to develop cancer. After that, lawsuits started happening, and patients who were heavily exposed to Roundup started suing Monsanto because they alleged that the lymphoma they had developed is because of the Roundup that they used. I was contacted by one of the firms in the spring of 2016 because of my expertise in lymphoma, asking me if I'm willing to look at the evidence and testify on behalf of the patients. Because most of the data was not in all cancers, was mainly in non-Hodgkin lymphoma. I said, I'm not familiar with the evidence. I know about pesticides increasing the risk of lymphoma, but I'm willing to study and investigate this, and I agreed to that. So I read and I studied, and basically I found out that I was convinced that there is a relationship. And with that, I agreed to testify. So I testified in the first three trials against Monsanto and Roundup. All of these trials were won by the patients. And the first one was in the summer of 2018, which was a big, big trial, Johnson against Monsanto.
I'm just going to pause there. So what we need to do is just jump off and jump back on, because I think Zoom's going to kick us out in a moment. So I'll just send you an email to rejoin you in a sec.
Is it the same link? I can just join the same link.
No, okay. I have to create a new one. Give me a couple of minutes.
No problem.
Thank you.